Today we will going to discuss a special type of topic is called birth injury. The birth injury is very important because it's not a one-man sword. We need gynae and ops people. We need pediatrics, CN. We need neuro, and as we are a blunt orthopedician, so all following above members are very helpful sometimes to deal with this birth injury. Factors predisposing to birth injury is prematurity, small maternal stature, maternal pelvic anomaly, prolonged or unusual labor, rapid labor, oligohydramnios, malpresentation of the fetus like breech, most common, cephalopelvic disproportionals, and deep transverse arrest of the vaginal part of the fetus. So, for birth injury, maximum antenatal checkup and they have been thoroughly judged by the treating gynecologist and obstetrician, and they can assume if there is any birth injury, they will give us refer. And the classification of the birth injury is soft tissue injury, head and neck injury, facial injury, cranial nerve injury, spinal cord injury, peripheral nerve injury, fracture along with torticollis. It is also called congenital torticollis. I will talk it later. And not but not and last but not the least, intra-abdominal injury. Along with this, we can get some other injury like long bone fracture and clavicle along with shaft humerus and femur fracture. Mostly we get femur fracture and humerus fracture. Now, abrasion and laceration may occur in scalpel cuts during the cesarean delivery or during instrumentation of the delivery like vacuums and forceps. And infection remains the risk, but most uneventfully maximum heal because of by the grace of God, and there is innate immunity of the child. And we used to get many devastating injury in the child, but that is automatically healed because of influencing growth factors, I think. And the management of this type of injury is careful cleaning, application of the antibiotic ointment, but not providing iodine. Please, you have to take a note. Providing iodine is recently going to obsolete. You can apply an sopramycin. You can apply fusidic acid ointment, etc. But don't apply providing iodine. It can cause blister. It can cause reaction, and it also has an effect of diabetes of neutrophil. So it can and along with it can cause bad strain. So wound healing is an issue for that providing iodine ointment. Now, observation and laceration occasionally require any suturing. Only observation and just take care, it will heal automatically. Now, sometimes we can get subcutaneous fat necrosis also. It is irregular hurt, non-pitting subcutaneous individuation with overlying dark sea red purple discoloration of the extremity, face, trunk, or buttocks may be caused by pressure during the delivery. And no treatment is necessary. Only subcutaneous fat necrosis sometimes may be calcified, and but the treatment actually the treatment of this type of subcutaneous head necrosis is counseling only, counseling and reassurance, that's all. Now, we are all very well known to this picture from DC Datta, and see this is the cross-sectional anatomy of the skull and fetal brain, and this is the capul lesion, this is the cephalhematoma lesion, this is the subglial hemorrhage, and this is the extradural hemorrhage, and subdural hemorrhage will present there. Most commonly, child and old age subdural hemorrhage is very important. or is also called sick baby syndrome. But during birth, maximum scalp injury is scaput or sepal hematoma, and glial subglalar hematoma is very rare, very difficult to diagnose and very difficult to treatment also. So as a whole, scalp injury is containing this caput huxerinum and sepal hematoma, subglial hemorrhage, skull fracture like linear or displaced, and intercranial hemorrhage sometimes. So caput succedatum, edema of the presenting part, presenting with the pressure during the vaginal delivery. This is a serosanguineous, subcutaneous and extraperiosteal fluid collection with a poorly defined margin, non-fluctuating. And cephalohematoma is a periosteal collection of the blood between the skull and the periosteum. It may be unilateral or bilateral, and appear within hours of the delivery as a soft fluctuating swelling on the side of the head. And the cephalohematoma never extend beyond the edge of the bone and across the suture of the line like this. It cannot extend from the sutural line because it is sub periosteal. And sometimes X-ray can be associated with this type of fracture. And subglalar hematoma is I already shows, but this type of subglalar hematoma is in this lesion is in this lesion gala aponeuta is called gala aponeuta. It is a very tendinous fine deep fascia like structure over the bone, and this bleeding is massive, so sometimes may need blood transfusion and you have to take help of neurologist, and sometimes very rarely it needs causalization. But cephalohematoma can be aspirated, but all the cephalohematoma and caput must be take care of sepsis, antibiotic, and for hyperbilirubinemia we can give phototherapy, as you all know. Now most important part is brachial plexus injury. On regards on neuro and ortho, the risk factor is macrosomia. Macrosomia means you already know a big baby in the diabetic child. The main things just want to focus that there is a question in MCQ: what are the growth factor responsible for fetus growth? In that case, or you have to know thyroid, then you have to take care of insulin like growth factor 1, and sometimes insulin like growth factor 2. Now where is a diabetic mother, that's insulin like growth factor is the problem. So the macrosomia is most commonly found in diabetic mother, and there is also associated with thyroid problem. And shoulder dystocia, you know, all know, and the instrumentation delivery and malpresentation all are the risk factor for brachial plexus injury. Now the most common brachial plexus injury we encounter is called Erb's Duchenne palsy. It is the root value is C5 C6 and is the most common type injury, birth injury, nerve injury actually, and it is lack of shoulder motion. The involved extremity lies adducted, pronated, and internally rotated, and the moro, biceps, and radial reflex are absent on the affected side. And grabs reflex usually present. Grabs reflex usually present. Mind it. Grabs reflex is usually present, but moro, biceps, radial reflex are absent in the affected side. Our palsy may be associated with the injury of the phrenic nerve also, and in because it is inhibited by C3 C5, but Erb's points is on C5 C6 at the top of the brachial plexus. And this palsy also called as policeman tip palsy. See, when the policeman takes the tips from any our road, so this is the attitude of the limb, and this is the same attitude. This is called Erb's Duchenne palsy. Now Klumpke paralysis. Klumpke paralysis is little bit lower injury of the biceps, sorry, of the brachial plexus root, and this is called C7, C8, and T1. It is very rare, and on weakness of the intrinsic muscle of the hands and long flexor and wrist and the finger. The clawing is the clawing, but not the writing. Grabs flex is absent, and bicep reflex is present. Here, biceps reflex is present. If cervical and sympathetic fiber of the T1 are involved, then it may be associated with the Horner's syndrome. Horner's syndrome is characteristic by ptosis. Actually, it is a pseudotosis, then meiosis and anhydosis. You all know all of this, and this is called Horner's syndrome. This and sometimes hematoma of the sternocleidomastoid muscle associated with the fracture of the clavicle and humerus. I will take class on later the sternocleidomastoid muscle and injury, but here the clumsy paralysis and is for lower end, and and the grabs reflex is absent, but bicep reflex is present, and Horner syndrome may be associated because of this T1 nerve root. So, and last but not the least, it is very rare. I even don't read this in our undergraduate level. When we are giving exam, we just know this. This is called total brachial plexus palsy. Is called Kerr's palsy, Kerr paralysis. The most distribution of all clinical feature is adynamy, muscle hypotony, and positive scarf symptoms, and sometimes is associated with diaphragmatic palsy also. Then is called Cofferet syndrome. Cofferet syndrome and Kerr paralysis. No need to mug up this name. You just know that may be occur. And the treatment of this up palsy, complete brachial palsies, or clumsy palsies is only conservative, and you have to just do a diagnosis, and you have to counsel the parents and family member that that is a small injury, and you have to be very gentle, and you have to be very polite during the counseling. Otherwise, today is the era of medical legal negligence. No complication is accepted, all are negligency. So they will repeatedly ask, sir, is there is any fault, is there is any problem. You have to be very confident enough to counseling, during the counseling of particularly mother and the outside person like fathers and other family member. It will heal automatically by the grace of God, but you have to do some IOS treatment, like you have to give a splint, and you have to involve the mother by a massage, gentle physiotherapy. But if it is associated with fracture, don't allow them to do massage, just give a splintage only. And if they are asking for, sir, if you want to give any medicine, you just can add vitamin drop and vitamin D3 drops, that's all for IUS. But and I repeatedly told, all the nerve palsy in the childhood age, maximum is herbs and clamke, and very rarely complete, it will automatically heal. Now regarding the treatment, we should know the all the brachial plexus types. One is neuropraxia, one is actinotemesis, one is neurotemesis, and last but not least is avulsion with preganglionic discontinuation of the spinal cord. This is worst. Okay. And sometimes when it is affected with the diaphragm, the initial treatment is oxygen respiratory failure may be treated with the continuous positive pressure and ventilation, and and garbage feeding, and plication of the diaphragm may be needed, and if any pediatric surgeon recommend. And also we can get laryngeal nerve injury. Symptoms will be stridor, respiratory distress, hoarseness, cry, dysphagia, aspiration. Diagnosis is on by direct diagnoscopy, and treatment is small frequent feeding may be required to decrease the risk of aspiration, intubation, and sometimes tracheostomy. But all the intervention and is very much indicated when this bilateral paralysis intend to produce more severe distress, and therefore require intubation and tracheostomy placement is more frequently. But remember, maximum laryngeal edema will subsided, and sometimes laryngomalacia is a differential diagnosis, so we should keep in mind. And if we can get any type of respiratory distress after the birth, we should consult our neurologist. Maybe we can take an X-ray. Maximum cases is transient tachypnea, and but very rarely there is respiratory disease in the newborn or hyaline membrane disease, as you all know. So they may need herb factor or treatment like that. But I just want to say that approach, and that diagnosis in proper time is very mandatory to rule out all type of this disease, disease possibility. And you should always take help of other expert, otherwise you can lose the child. And last but not the least, our domain is very easy domain is fracture. And the clavicle is the most frequent bone injury in the neonate during the birth, and the most often is an unpredictable, unavoidable, and complication of a normal birth only. The infant may be present with a pseudoparalysis. What do you mean by pseudoparalysis? Pseudoparalysis is patient or child will not move his that limb. It is called pseudoparalysis. There is no neurological deficit, but he will not move that limb. What are the condition where we can get pseudoparalysis? First is fracture, second is septic arthritis of hip, third is scurvy, or and last but not the least, lead poisoning may be associated with this type of pseudoparalysis. Why? Because of pain, he or she cannot move the limb. So pseudoparalysis, just keep in mind. And there is also a term is called toad paralysis, actually found in the child after epilepsy. Is post epileptic paralysis, also called toad paralysis. It's just for an correlation or differential diagnosis of pseudoparalysis. But pseudoparalysis must be associated with unilimb, but toad paralysis is all over the limb, whole limb. So this is an differential diagnosis. And any type of fracture in the pediatric bone, you have to know the anatomy. The pediatric bone is covered by a thick periosteum, just like a tree. Tree See there, this is the cover. This means highly thick and tough the periosteum it represents, and this is the bone. When there is the fracture, there must be an hematoma. So angulation may be up to 90 degree, but there is a presence of hematoma. This hematoma and periosteum will automatically healed up by a huge calcification, and after this malunion will be very easily remodeled by their special remodeling capacity of pediatric bone. Touch mm, I already described it in the previous classes. See, there is a fracture of humerus. After that, this is maybe displaced, but there is a good callus formation. Then it heal. Then it become a normal humerus. Again, there is a shaft of femur fracture. This is the angulation. This is the displacement. Now you can tell, sir, there is 90-degree angulation. Is you are telling it may be accepted, but what about the shortening? Yes, regarding this shortening, I can tell one special character of pediatric bone is when any type of insult in the pediatric bone, like any injury, like any operation, like any osteomyelitis, there is a huge increase of blood supply. Now, in respect of increasing blood supply, the physis of proximal to distal of this insult will get maybe hyperactive. Due to hyperactiveness of this physis, this bone will grow rapidly. So and there is in all the bone has been beautifully programmed from his birth. Whatever shortening is done here, that will be corrected by the hyperactiveness of the physis. So beautiful planned our child, that if there is any shortening, that will be equally planned and managed by the hyperactiveness of the physis. Okay. So and what but the mother will ask, sir, what you will do for this child? You will do a small bandage. This is called dissolved bandage. This is only eye wash. You can put a small ball roller bandage under the knee, or if there is humerus fracture, you can just splint. That is sufficient. No need to do any reduction. No need to do any movement. Just allow them to do proper hygiene maintain. That's all, and that will automatically heal within 1 to 2 weeks. And so best treatment is assurance and just sprintage, that will heal beautifully. And last but not the least, sternocleidomastoid injury is called congenital muscular torticollis. Diagnosis only by physical examination. Radiograph should be obtained to rule out the abnormality in the clavicle cervical spine. Ultrasonography may be useful, both diagnostic and prognostic manner. And if you need any type of actually this sternocleidomastoid injury is only conservative, but I will take a long another class on this pseudo tumor, or this is the hematoma of the sternocleidomastoid muscle, and it will get fibrous in the long run, and it can cause a torticollis. And just I am telling the topic, and I will discuss it in the next topic. And last but not the least, it is a intra-abdominal injury may be associated, but most common is liver hematoma, spleen hematoma, adrenal hemorrhage, and annular hemorrhage. But I just want to clarify, or I want to give you confident about all these big hematoma, or all this injury in the fetus. Don't do any panic, because God has gifted a very good software uploaded in the child. They all the injury will automatically heal. So maximum cases need no intervention, and only counseling is sufficient. And lastly, the conclusion: the recognition of the trauma and careful physical and neurological evaluation along with documentation, which is very important, and establishment whether any additional injury exists or not. Last, and the injury may result from resuscitation also. Assess the symmetry and the structure and the function, and specific examination such as cranial nerve, joint range of motion, scalp, and the skull integrity also. And last but not the least, I just want to add a point to our new resident. When you will get posted on gynae ops, after any type of normal delivery or cesarean section, or any type of after settle down your job, you just have a recent guideline is you have to do a skeletal survey, or a orthoneuro skinning up, because sometimes you can miss a CTV, sometimes you can miss a spinal bifida, sometimes you can miss any birth injury. But if it is documented and it is treated early, or any fracture, and I think we will not get any medical cases, as well as we can manage our newborns with care. Thank you.